Welcome, everybody. Welcome, attendees and participants. It's great to see many of you here, some familiar names as well. I can see an attendee list. My name is Aysel, and I am the coordinator of this project AHEAD. I'm part of the Wemos team, a Dutch civil society organization based in the Netherlands. This webinar is one of the last in the AHEAD project, which is coming to an end at the end of May this year. So we are delighted to share with you some of the key policy asks to tackle medical desertification in our project countries and that were developed during the consensus building sessions. For those of you who are joining the AHEAD webinar for the first time, AHEAD stands for Action for Health and Equity, Addressing Medical Deserts, and aims to reduce health inequalities by addressing the challenges of medical desertification in the European context. I will share more on the project and also the aim of this webinar shortly. But first, some house rules for today. Firstly, if you have any questions or comments during the webinar, please type them in the Q&A box. We will be monitoring that throughout the webinar and hope to answer as many as possible. This webinar, as you can see, is being recorded, and we will share the link to the recording after the webinar is done and uploaded online. So, as I mentioned, in today's webinar, we will present you the key policy asks that were developed in our project countries by our consortium partners and the panel that you can see here today as well. So I would like to take a minute to introduce everyone. Firstly, we have our Romanian colleagues here, the Center for Health Policies and Services, today represented by Dana Farcasano. Hi, Dana, the president of the organization and the research lead in our project. We have partners in Italy, Cittadinanzattiva, and here it's represented by Bianca Ferraiolo, head of representative office of the EU Brussels in Brussels. So hi, Bianca, good to have you here as well. We also have Media Education Center from Serbia, here represented by Professor Dr. Milena Santric-Milicevic, our HRH expert and a professor from the Faculty of Medicine, University of Belgrade. Good to see you, Milena. We have colleagues in Moldova as well, and they're part of the National School of Public Health Management. And today, we will have a video intervention from them done by Sergio Otgon that you will see also soon, who is another expert in HRH. Another colleague from Wemos from the Netherlands is represented here by Corine Hinlopen, our global health advocate and the project lead. Hi, Corine. Also representing the country team for the Dutch context. And we also have another Dutch partner, VU Athena Institute from the Netherlands, represented by Abdul Azad, who is a postdoctoral lecturer and a researcher. His role today is behind the scenes, so you don't see him on a panel, but very much involved in the project and the preparation of today. What we also have the pleasure of having Katarzyna Ptak from DG Sante with us today. Hi, Katarzyna. Katarzyna is a policy officer in the unit of charge of performance for national health systems in DG Sante. She works on access to healthcare and healthcare workforce and contributes to the unit's work of the European semester and knowledge building for health systems in Luxembourg and Spain. Katarzyna will share her reflections and thoughts on what we will be presenting later today once the presentations are done. And as I mentioned, there will be a Q&A session. So please use that box to send through your questions that we will be answering at the end. So that is our panel and sort of the background, but I want to set the scene a little bit more on what we'll be discussing today to provide you further information before I open the floor for the panel. Firstly, I want to brief you about the concept of medical desertification and our definition. In the initial stages of the project, we carried out a literature review to better define the concept of medical desertification. Based on a thorough review of scientific studies, media analysis, and other research tools, we concluded that it is a very complex concept with many dimensions. The challenge was to summarize it and make something short, what we can say is that medical desert is an endpoint of a complex process called medical desertification that implies continuous and increasing inability of a given population to access health services in a timely and contextually relevant manner. There is a page on the HEAD website that provides further details and elaborations on this definition and the specific terms that we used for that as well. And you will see that in posted, or you can already see the link to that in the chat. Additionally, what makes our project HEAD is unique is the methodology that we implemented for the participatory consensus building. It's produced under the leadership of VU Athena and in collaboration also with our consortium partners. And the policy options that will be presented today have come out from the workshops that were taking place in the 5 project countries. The essence of this methodology is bringing the range of stakeholders together from local to the national level in a phased approach and contextualized manner. The idea is to create a space where everyone is heard and the solutions are tailor-made, locally owned, and sustainable. We actually held another webinar on this methodology last time, and you can also watch it on our website, and there will be a link to that in the chat, and another link to show you the PowerPoint that specifically conveys the key concepts of this methodology, for those of you that are interested. Without further ado, I would like to actually ask the panelists to present their policy asks for each country. And the first up, we indeed have our Moldovan intervention as a pre-recorded video. So I kindly ask to pull that up, please, and show.
Hello, dear guests. The HEAD project implementation team in the Republic of Moldova organized and conducted several consensus-building exercises with the local and national authorities involved in the management of human resources in health. During the roundtables held, the participants' knowledge regarding the topic, the attitude of medical professionals towards medical desertification, and the factors that determine it, and the current policies in human resources in health were explored. As a result, several solutions have been generated, all of them potentially effective on mitigating the phenomenon of medical desertification in the Republic of Moldova. Let me just highlight the most important 5 solutions identified in Moldova. First, promote medical deserts phenomenon on the political agendas of local and central authorities. Improve the existing policy options to attract and retain healthcare workers in remote and rural areas. Diversify non-financial benefits for healthcare workers and increase financial incentives, especially for professionals in medical deserts area. Move please to the next slide. The 4th and 5th solutions were increase advocacy for improvement of overall working conditions in the health system, ensure free for all access to the information on open vacancies in the healthcare system, thus increasing the chance to recruit professionals with the highest demand. This set of recommendations will be organized as a policy brief and will be transmitted to the health authorities from Republic of Moldova and will be available on the ahead.health website as well. That's all from my side. Thank you.
Great, thank you so much for the video intervention. And now it is time for some live presentations. I would like to pass the floor, well, first pull up some slides on the screen, please, and pass the floor to Bianca from Italy to kick off once the slides are up.
So good morning, everybody. Given the complexity of the problem related to the medical desertification, the proposals that I will tell you in a minute have been made keeping in mind the need to address issues related to medical desertification, indeed, with a tailored and participatory approach. So at the end of the national phase in Italy, some proposals have been made. The first one, as you can see, is to allocate more resources for both health personnel and technological advancement, and so the widespread diffusion of broadband, especially in inner areas, of course, and remote areas which present more critical issues. Also, there's the need to ensure the training and updating of digital skills of health personnel. Of course, the best thing would be have ad hoc agreements and platforms to be developed in collaboration with them. And also what is fundamental is the dialogue between all the stakeholders in order to ensure, as I said earlier, a participatory approach and ensure structural policies, co-design, and the organization of these services. So to respond the challenges in a coherent and informed manner. But also, what is crucial is it will be to have an annual census update and publication of data on health professionals made by the Ministry of Health and professional associations. The fifth proposal was to grow related to the growing inattention to the segments of the population that fall within the development age, makes imperative to collect and elaborate data and indicators that allow for the adjustment and planning of healthcare work dedicated to them. And the last proposal is that it is necessary that the essential levels of care can measure the quality of territorial care provided, and it will be useful to develop an atlas of the medical desertification that takes into account indicators developed for each local authority. Of course, in order to be able to proceed with an extensive and concrete monitoring of the actions put in place. And please allow me to make a final comment, because as I mentioned earlier, one of the major difficulties we encountered in the progress of the work conducted for the AHEAD project involved the lack of certain up-to-date and easy available data related to the health workforce. And this not only does not facilitate the planning of intervention and allocation of resources, but also creates issues related to the transparency of information that should be easily accessible, at least to the professionals. Thank you.
Thank you very much, Bianca. We can move on to the Netherlands now next. Over to you, Corinne.
Thank you very much, everyone. Thank you for this opportunity to share the Dutch policy options. My time is limited, so I'll dive right into it. It is important to note that on the basis of the research that we did at the beginning of the project, we chose a pilot study area to implement the consensus building methodology, where especially the GP situation is causing headaches. And you will see that I have structured my results along two main lines of thinking. Policy options that can be implemented at a local level versus those that need national level action. And policy options that could lead to more supply of GP care and those that aim for a lower demand of GP care. Starting with the local level. In order to increase the number of GPs, the local level stakeholders took up the idea to promote the attractiveness of their region. They're a very proud bunch of people and they have many ideas on how to do this, including even asking Dutch celebrities hailing from the region to make the PR for them. However, other interventions to increase the attractiveness of their region and of rural and remote areas in general need to be facilitated and supported by decisions at national level. I'll come back to that later in the second slide. But in terms of decreasing the demand for GP care, two local level solutions were formulated. One, improve cooperation and coordination between primary and community care providers. This has started some time ago already and is yielding promising results. The idea is that everyone in need of health, care, or social services accesses the right form of care directly without a detour through the GP offices, something that happens a lot. Secondly, support the people who have difficulty navigating the complex Dutch system for healthcare, social services, home care, and informal care. The local branch of the elderly organization has developed a so-called guide to social and care services that they distribute also in hard copy among their members. And they also provide volunteers to guide those in need through the system. Now, during the national dialogue sessions, and that's my second slide, the following potential solutions were discussed. Increasing the supply of GPs by making the profession more attractive could at least partly be achieved by reducing the administrative burden and unnecessary bureaucracy that GPs have to deal with. This is a well-known problem and was prominently put on the agenda by the stakeholders in the case study area. But of course, this is outside their direct sphere of influence. So in the national dialogues, this issue was therefore discussed in some detail. It was pointed out that there is a program going on called Deregulate Our Healthcare that aims to abolish irrelevant and unnecessary administrative tasks. However, it was acknowledged that new rules and procedures are added at almost the same speed. Plus, that not all GPs are aware of the change requirements, so they're still adhering to old and unnecessary routines. On a brighter note, in the recently negotiated national integrated care agreements, stakeholders have agreed to reduce the administrative burden with 5% point in 2025. Another solution to increase GP supply that was put forward is to implement a mandatory deployment measure for GPs in areas at risk of medical desertification. During the national dialogues, this option was considered to be, and I quote, interesting, exciting, and complex, and this seemed to be code language for impossible. The junior doctors present warned that such a prospect would probably also demotivate medical students to choose family medicine as their specialization. Now, in order to reduce the demand on GP care, the following two options were on the table. Facilitating further task shifting and closer cooperation between GPs and other health and care providers, especially geriatric specialists in regions with many elderly patients. But this is not very straightforward in the Dutch healthcare system and would require an extensive overhaul of the different funding streams. Moreover, there are also shortages in the geriatric specialty. Secondly, improve the quality of digital healthcare delivery, as well as electronic communication between care providers. Both GPs and patients suffer from malfunctioning digital platforms and poorly connected and coordinated ICT systems in healthcare. I'm happy to add here that there is a new law in the making to improve this. In addition, there is need for more extensive rollout of e-health interventions for those groups for which this works well, including nudging the GPs to adopt such interventions at a larger scale. I'm stopping here. Thank you.
Thank you very much, Corinne. We can move on to Romania now. From Dana.
Okay, thank you, Aysel. Good afternoon, colleagues, partners, participants to our webinar. Regarding Romania, of course, we gathered and used the evidence to inform the policy options and measures to counteract the medical desert. And we invested a lot to validate these options and measures at all levels, local, national, and with we invested in evidence to inform the policy options, and we invested a lot of time and effort, very rewarding, by the way, in validating them at all levels and with a variety, with a large range of stakeholders. In Romania, we invest a lot in hospitals and in infrastructure, which is very much needed. But to counteract the medical deserts, we have the key solution of developing and better regulating the primary health care. It's the only way to assure universal health coverage. The most important policy options are therefore to acknowledge, to value, and to invest in the frontline healthcare workers, and to develop, ideally at each community level, networks of providers. We need to better regulate the practice of the primary healthcare practice, to decrease bureaucracy, to incentivize the group practice of the family medicine, including the multi-generational practice, to support the professional development. They are considered private, independent providers, and somehow their role is not valued as needed. We need to support their professional development from, I don't know, evidence-based practice guidelines to exposure and participation, to international professional networks, to research, to best practice, to best international and European practices, while we redefine tasks and clearer attributions for each member of the primary healthcare team. Primary care is not only family medicine. Primary care is the team that should include the nurse, the community nurse, the Roma health mediators, the community pharmacist, if exists. We need to also, as you can see in my second slide, we need to use all resources we have. And I'm speaking here about, for example, the graduates of the medical universities who do not pass the residency exam. They usually go to pharma, or they leave the profession, or they stay at home and learn for the next year residency exam. We need to find the role for these professionals, to invest in them, in possible work at the community level, in what we have as medical deserts, of course, under the supervision of a family doctor. But it's a resource which is for now neglected. We also need to find those specific activities and tasks for which nurses and midwives can have contracts as providers, as independent providers. All these activities would allow a better healthcare delivery at country level, at community level. Other measures to counteract the medical desertification are, of course, related to telemedicine or mobile services. There are initiatives of the government, and we need to acknowledge them. But this is not enough. We need to prioritize, we need to plan, we need to fund mobile health services, for example, first in the most remote and underserved community. The involvement of local authorities, as you can see on my third slide, is also critically important. We need a strategy and interventions to increase their knowledge and their understanding on how they can contribute, where they can contribute to a better healthcare deliveries. And it is not only one solution to fit all. We need tailored interventions for the most vulnerable rural municipalities, for example, with a wise and tailored use of funds provided from different sources, including the National Recovery and Resilience Program. Another critical policy options we identified, as you can see in our fourth and last slide, is the medical education. We need to update the educational curriculum on a regular basis, at least for the family medicine. We need to increase the share of practice. We need to increase the network of family doctor practices in rural areas accredited for training. Very important is the continuing medical education, which is presently based on demand rather than on offer, rather than on needs and demand. And somehow the online webinars and the training and the significant offer of webinars and online trainings decreased the quality of the continuing medical education for nurses and for medical doctors. To rethink it, to reconsider the continuing medical education is critical as well. This is a selection of the policy options we identified. There are many more. We are still in the process of prioritizing them on short term and medium long term. But what I proudly share with you is that people are interested, stakeholders are interested to continue working even if our project will come to an end. And I can promise you that we will do that. And my last remark is just to support Bianca's earlier statement. We need data. We need good quality data, transparent, granulated, to continue providing evidence to inform our policy options and measure we promote at national level. Thank you. Ready for questions.
Thank you so much, Dana, for intervention and clear intervention. Last but not least, we have the Serbian intervention by Milena. If we can pull that up next. And Milena, the floor is yours. Thank you.
Thank you, Aysel. Good afternoon, good evening, good morning. I don't know where our colleagues are coming from. And first of all, I would like to say that we from Serbian team are very grateful to our respondents for their support throughout the whole process of developing of policy options to combat medical deserts. A few remarks about how it was the policy options were developed include that we have used the methodology developed through the AHEAD project that includes medical desert diagnostic tool and also participatory consensus building methodology. And more from that you have heard from Aysel, and you will be informed through our previous sessions. So as all of my colleagues have said, this is a complex issue, and the medical deserts were seen also as very complex from our respondents and our participants. And thanks to them multidisciplinary, and thanks to their different views and perspectives they took during our roundtables. We have come with many policy options, among which some are mainly or should be led by government, and others should be mainly led by local or jointly local and government policy options. First of all, government level policy options are government level because it's not only about the Ministry of Health, it's not about only labor sector, it's not about only education, it's about all of these necessary inputs that we need to combat medical deserts in Serbia, especially financial and economy sector. So what we saw from our work with our stakeholders, experts, and all our participants, the valuable input was towards structural support that needs to be built to improve the access to quality healthcare in medical deserts. That is about establishing the task force, a national body to combat medical deserts, roots and consequences, both. That means that this task force or national body should consist of also and predominantly and as a priority people from medical desert, that are patients, that are providers from medical desert and local authorities for medical desert that could help establishing the further solutions for combating policy options. Secondly, to regulatory monitor indicators of medical deserts is of utmost importance. Otherwise, we cannot know what is going on, whether our work is good or is unsuccessful, what should be changed or should be standardized. So we should use, in that sense, already available or develop or upgrade national and local information system for population health and national information system for health workers and healthcare with the indicators that we are seeing as valuable for medical deserts. Please, next slide. Additional government level policy options are about regulation. So what we want is to implement, we saw that is necessary to implement regulatory acts that specifically combat the development of medical deserts, including building supply of competent and motivated health workers in medical deserts through more subsidies and incentives for health workers. Both benefits and higher salaries are meant under these terms. Also, more jobs for board-certified health workers in medical desert and mandatory health worker practice in medical deserts for students that are at fellowship, internship, or residency program in medicine. The third government level policy options are about, please next slide, are about government inputs for modernization of healthcare delivery in medical deserts. We see that it is important to improve efficiency in healthcare delivery in primary care. And what came out as a possible solution is about mobile healthcare practices, implement and enable contracting health workers for these kind of practices, such as mobile doctors, mobile nurse and home care, mobile labs, mobile pharmacies, etc. At the next slide, you will see both government and local level policy options that include building competency of health workers, which will build also a healthcare effectiveness, and the actual solutions are about assurance that more places for health worker training should be closer to the medical deserts. Furthermore, developing training curricula for rural health, because more medical deserts appear to be not city, but in remote areas. Creating health worker professional networks for electronic consultations and electronic teamwork together with national and international colleagues. As my colleague has said, building international and joining the international professional networks should be available also for primary care workers in medical desert and should be encouraged as well. Coaching health workers in medical deserts for telemedicine is something that we see as a priority, especially if we see implementation of mobile practices and mobile pocket size, let's say, telemedicine equipment, etc. So please, next slide. Government and local level policy options should also address the working conditions. We saw from our work that improvement of healthcare quality in medical deserts has to be hand in hand with increase of availability of medicines, increase of availability of modern healthcare technologies in medical deserts. Implement digital medical documentation, which is patient-oriented and not the one which makes double or triple burden to our health workers. Then build field work with equipment for mobile health practices and establish mandatory peer supervision and visitations of health workers to help them everyone value more their work and their competencies. Also to support both financially and regulatory the mentorship in healthcare in medical deserts. This was something that as a solution for always the posed question how to keep young medical workers in medical deserts. So thank you, my colleagues, and I'm also ready for your questions.
Thank you very much, Milena. And thank you, everybody, panelists, for your clear and concise presentations today, also with such rich content and while sticking to the very tight time restriction. Before we move forward, I just would like to remind everybody in your audience that we do have a Q&A part, and which is going to be interactive. So please write your questions in a box, and then we will try to answer them. And but before we move to that, I would like to invite Katarzyna to the floor to share your reflections, opinions, thoughts on what you have seen so far today on the policy options to address this. And the floor is yours, Katarzyna.
Thank you very much, Aysel. I hope you can hear me well. I would like, first of all, to thank you for this excellent presentation. It is great to join this webinar, to see again the great team of the AHEAD project. It's really my pleasure to accompany you on the way and to see the results which you have produced. We are 2 months away from wrapping up the work within this project. It's one of our 3 projects on medical deserts supported under the 3rd health program. And we are very curious and very happy to see this great investment. And I'm really happy to see also that we are 1 step ahead of the research activities, that we managed today to present the policy options, and not only present some ideas, but these are actually the policy options which were somehow validated in the consensus building process. So I congratulate you for this concept. I think this indeed is addressing a need of building the understanding of the challenges in medical deserts, not only in the our usual suspect environment of people, of health workers, of people involved in the organization of health services on the ground, but also allowing a more cross-cutting perspective involving other sectors. It was mentioned here, policy stakeholders responsible for budget planning, for social policies, for labor policies. I think that this concept is great, and I think that we will be able to show it to other member states as a good practice, good example of how to design policies. Because indeed the problems of medical deserts are very complex, and we cannot reach the feasible solutions without involving other stakeholders. I think we discussed it in one of the previous seminars, how important it is to build the consensus broader outside our usual suspects. I would like also to stress something. I think that everything crucial, important has been said by all the intervenants. I would like to welcome actually these conclusions. I would like to welcome a very comprehensive set of policy recommendations, policy options presented. I think you covered everything. What I would like to stress is that your analysis shows how different the medical deserts are. We are talking about different problems, different challenges, which are of course linked to the variety of the solutions in how healthcare delivery is organized in the countries, but also which is closely linked to the broader capacities. And the problems related to shortages overall at country level. I think, yeah, it's very important to make sure that we, when we are talking about the policy solutions, that we are context specific. There are no one-fits-all solutions. Your analysis clearly shows it. Nevertheless, I think that this project has a huge potential to show good practices, and this is what actually we've been also looking for, not only from AHEAD, but also from other projects working on the problems of medical deserts. So we will be certainly very happy to share these practices. And I was really very excited to hear that the work will not end in 2 months, that there will be some sustainability, especially from what I hear from Nana, is very reassuring. And we indeed hope that this is not only about the research and presenting the policy solutions, but that it will be followed up through the effective implementation on the ground. We would be really very happy to see it. So we will certainly accompany you through our country-specific work, and we'll also try to get some feedback from this work into our country-specific activities, not only the analytical ones and knowledge building, but also policy steering, which is, of course, the nature of the European semester, where we can recommend member states to address certain shortcomings in health systems, and actually issues related to healthcare workforce were very well, quite predominantly present in the recent semester cycles, and the country-specific recommendations called for efforts to address shortages, including unequal distribution of staff in 17 member states in the 2 recent cycles. So this is, as you may see, a very important issue for us. I was also very happy to hear that when you think that in your recommendations, the policy options are not restricted to the purely human resources policies. Of course, they are crucial. They are the first priority for us. We have to look at all the possible angles to shape the health workforce. We need to solve the problems of medical desert. So this is about the, as you say, about the education. We have to shape this workforce through education, but also we have to think of the working conditions, improve working conditions. We have to think of each profession, whether this is the general practice, not only limited to doctors, but also the nursing profession. But we also have to think about other stakeholders who intervene in providing care in the social sector, integrated care, and so on. So this is critically important. I was also happy to see that you think broader, that you actually also consider adaptations in the delivery of services. I think this is important. This goes together with the need for investments, also involvement of stakeholders, as I mentioned, but also the issues of reducing administrative burden, and making sure that health workers can indeed focus on the medical aspects of care. These are very, very important issues. I think that I had managed to show the importance of the journey to achieve the good solutions. And I am really curious to learn a bit more about the policy dialogues. How did you find the involvement of all the important stakeholders, and whether you think that this is a good way forward for other countries who struggle with the problems of medical desert? So I will be really curious to learn more about it. I think it's also summarizing my intervention. I would like also to talk a little bit about how we can bring this precious knowledge, valuable outcomes to the EU level. So as you know, we have some initiatives ongoing, and I think that the input from your work would be critical to feedback to our work on health workforce planning or on the skills strategy, but also, as I said already, for our country specific activities. So yeah, we will be happy to continue the cooperation and to explore together how we can do it. Yes, so just to end some messages, we should, what comes out very clearly, we should measure better the problems in medical deserts, get a better understanding through a better evidence. What are the challenges and hurdles? We should involve the right stakeholders in the policy solutions. We should shape our health workforce for medical deserts, but also support this health workforce. And I think what is very critical, we should evaluate the policy solutions. I would like to thank you very much. And I will stay with you for the discussion or questions.
Thank you so much, Katarzyna, for your intervention, for your thoughts, for your reflections. Really great to hear some of the things we also resonate with a lot. One thing you mentioned, I think, in your reflection is that contextualization is super important. And that is really, I think, in my reflection as well as a coordinator, was a big challenge for us to make sure that we have standardized practices to ensure implementation across the board, but allow for that contextualization element. And it's really important, even we always say context is everything with all of our approach. So that's really important and great to hear you recognize that as well. And I like how you summarize sort of EU level overarching summary of the reflections that can be applied actually also beyond the countries that you that you've seen today in the presentation. So thank you for your reflections. And yes, please stay on for the Q&A. We are a little bit behind the time, but we nonetheless would like to hear some more reflections also from our audiences. I can see that there was a question that has been answered. So that is good by our colleagues. Thank you very much. But there's more. Please send through your questions still. But I would like to ask a question to the panel as well, nonetheless. Thank you everybody for your presentations. Quite rich content as well. But perhaps can I ask you to sort of summarize in your countries, and this is for everyone to answer, what can be done to take this further and to implement these in your context? Are there any specific requirements that you think are really necessary or asks for the policymakers to take this further? And it's also an opportunity perhaps for you to highlight a specific feature from your country context that you think makes this particularly a challenge, or maybe easier, depending on your country as well. But who would like to go first? It is on volunteer basis for this question, so please raise your hand. Dana, please go ahead.
Thank you, Aysel. Well, thank you first all colleagues, and thank you, Katarzyna, for summarizing and bringing additional value to our webinar. I must acknowledge what the present government did and is doing in Romania regarding better access to health, investment in health, healthcare delivery, investment in infrastructure, and not only. It's the first time we have also a special ESIF-funded program for health beyond the recovery and resilience one. The problem is how we better coordinate these interventions. Policy options are in the some of the policy options are already embedded into the national legislation. And I'm giving you the example of telemedicine. In primary healthcare, telemedicine services are reimbursed by the mandatory health insurance. But we need regulation, we need infrastructure, we need practice guidelines and standards to make sure that the service provided, the visit, the consultation is safe, has good quality. This is where I see a fracture. We have legislation, we have beautiful documents, we say we have funds, but we need also coordination among the measures, and we need not only coordination among the measures, but tailored solutions or policies made through consensus. And I'm happy we did this work because somehow we contributed to this grassroots-based solutions. Yes, we discussed with not only with the patient, with the people in the communities, in the medical deserts. We asked them for problems and solutions. Then we discussed with the local authorities, with the few professionals. Then we took these measures up at central level. It's a process, it's complicated, but for sure we need tailored solutions and better coordination between programs, policies, programs, investments.
Thank you, Dana. Thank you very much. Would anybody else would like to reflect? We have a few more minutes, but I would like to hear from other teams. Both Karina and Milena. Milena, you can go first, then I think, yeah.
Well, I will just say something very shortly. I completely agree with all what has been said, and I'm very appreciated for the upgrade that we got from Katarzyna, that something really is necessary. And from Serbia, which is a non-EU country, and a bit different political atmosphere or social construct, etc. Buy-in from stakeholders should build first, we should have first critical mass. So advocacy, promotion of solutions, internal communications with all of our stakeholders, building our strengths and building our capacities. And of course, nothing without EU support is possible. Unfortunately, we are not so, let's say, competent or not so strengthful, or we are not so powerful to complete all what we want. Maybe some small parts, but we need to solve medical issues and medical deserts roots and prevent consequences. And for that, we need more people on our side. Thank you so much.
Thank you, Milena. The root causes, indeed, very important. And thank you for your reflections. Corinne, did you want to reflect very briefly? You have 1 minute.
Very briefly, yeah, I'm mindful of the time. Well, I would like you to bring into the discussion the issue of ownership. Who is actually the owner of the problem? We have seen in the Dutch context, I mean, I didn't say something about, code language for this is impossible for nothing, because what I found is that at a local level, there's lots of energy and dynamic motivation, so to speak, to actually tackle it, but their sphere of influence is limited. And when you elevate the problems to the national level, there's a lot of talk about, yes, but we're doing already this, we're doing already that. So they're not taking ownership of what is happening at local level. And that is really, that is creating a sort of a schism, or how do you say that, between local level and national level. And it hinders the real solutions, so to speak. Thank you.
Thank you very much. Yes. I think that's also an overarching concern across the countries as well in some regards. But colleagues, I'm conscious of time. It is now 1500 and it is time to wrap up the webinar. I think we have answered the questions from the audience, but I would like to thank all of you for being here, the audience. I would like to thank our wonderful panelists for your presentations and interesting discussion. And also thank you, Katarzyna, for your reflections as well. You will now see one slide that summarizes how to keep in touch with our head activities, which includes the link to our website, www.ahead.health. Here you can discover more about some of the things that we mentioned today, the medical desert diagnostic tool Milena mentioned, the research methodologies, the stories also that were affected for medical deserts, and so much more as well. So please have a look and sign up to our newsletter. We still have some months to go, so you will see more on that, but and keep in touch. And if you have questions, there is also a way to get in contact via there. One thing I wanted to mention before we leave is that please consider contributing to our end of project evaluation. You can find a link to that in the chat that will be posted in a few seconds. And also you can find it on our socials and the website. You will see a link after this webinar as well with the recording and the evaluation. So I already thank you very much in advance for your contributions and consideration for that. Stay tuned for our next and last webinar at the end of May. And thank you once again for attending and have a great afternoon. Take care, everyone. Bye-bye.